Hello, this is Dr. Janish. This video is going to be the excision of a volar ganglion cyst from a wrist. As usual, the incision is planned and marked with a skin marker. You'll see some dots around the cyst. This was put there not only for visualization for the video, but I also do this when I see patients in the preoperative holding area to confirm the borders of the cyst. These often change when patients are under anesthesia, and sometimes the cyst is hard to find. I've marked this in Langer's lines transversely, which is the way I like to excise these. Some surgeons do this longitudinally or lengthwise down the arm. I just feel that this creates a little bit better scar, and I'm able to get the cyst out without making a longer incision. The skin's incised with a 15-blade scalpel. Immediately below the skin, there's lots of important anatomical structures, and deep to the cyst is the radial artery. I use ultrasound in the office and map out the location of the artery preoperatively so that I don't have any surprises. In this case, I do know that the artery is deep to the cyst, and I will show you that at some point during the surgery. Here I'm dissecting down through the fat. You can see the cyst is poking through there right in the center of the wound. I find that ganglion cysts in this particular location are nearly impossible to get out without rupturing them. Usually purposely rupture the cyst at some point during the dissection to ease in getting it out. It also helps me define some of the other anatomy that may be tented up from the inflated or engorged cyst. This is my Volar cautery. This is used to cauterize some of the fine blood vessels going to the cyst. Again, I've already identified the important arterial structures in the area. These are being protected. This is the cyst. The cyst is deflated in that particular picture. Here I'm showing you the radial artery. It's just deep to that fascial layer. I'm trying to stay away from it. Do some more exploration to make sure that there's no additional cysts deep to this. There's not. We'll do some housekeeping and tidy up some of the final bleeders with the bipolar cautery. As usual, the wound is irrigated in the procedure with sterile saline. I'll start a layered closure. I like to close the subcuticular layers with monocryl, even if I am going to put in a final layer of nylon in the skin. I feel that this gives a much better cosmetic result. Oftentimes I'll simply do the monocryl in the deep layers as I'm doing now, and that will be the final closure. In this particular patient, I felt as I was closing it that the skin needed to be better everted, and therefore decided to use the nylon suture at the end to better evert the edges. And you'll see that the edges of the skin are somewhat puckered along the suture line, and that is done intentionally to create a better cosmetic result. There goes in the final layer of suture. This is the nylon. I'm going to be doing a running horizontal mattress. You notice I've left a loop of suture in the middle of the wound. That helps in removing the suture in the office next week. We'll cut both ends and the small loop in the middle, and then pull the suture out from either end. Some local anesthetic at the end of the case so that the patient wakes up comfortably and it doesn't have any postoperative pain. Again, I'm being very careful of that radial artery. Xeriform dressing over that, which is a greasy medicated gauze. And for volar cysts, I typically do not place a patient in a rigid splint. Many hand surgeons do. I find it unnecessary and like patients to start moving right away. I do put a gentle compression dressing on this area, consisting of Clearlex, sponge gauze, followed by Coban. That's the end of this surgery. I hope you enjoyed watching this volar ganglion cyst excision. There's many other good videos coming. Please stay tuned and keep watching as we post. Thank you.